Okay, so nice, easy, quick way to assess the shoulder joint. Shoulder pain will typically present sort of around the front of the shoulder, down the side of the arm. First thing we need to do is clear the neck, so the cervical spine can obviously produce symptoms down the arm. Typically, if it's going to be a cervical spine problem, you're probably going to notice pain coming below the elbow, perhaps pain up around the neck area, down around the back of the around the spine area there. If that isn't happening, then we can probably consider it to be a shoulder problem. Objectively, to clear the neck first, we're going to sit Rob down in the chair and we're going to go through some simple neck range of movement exercises. So first off, we're just going to get Rob to take his chin down to his chest. Lovely, and what I'm going to do is I'm just going to over press on the top, apply a little bit of pressure, hold it there, and again we're looking for a change within the patient's symptoms. Does it get better, worse, or stay the same? Then we're going to get Rob to take his head back and up as far as he can, and we're going to do the same, just apply a little bit of pressure, and we're just going to see if it changes the symptoms at all. And then come back up, and then we're going to get him to go right ear to right shoulder. So we're looking for range of movement, but also we're just looking for that change of the symptoms. And then the other way for me. Good, and back to the middle. And then if you just want to look over your right shoulder, and again we'll just apply a little bit of pressure, and then the other way for me. Good, and a little bit of pressure there. If the neck's clear, that hasn't produced any of Rob's symptoms, we can go onto our shoulder assessment. Now, there's lots of different things around the shoulder that can present in similar ways, so we're going to try and use one movement just to differentiate between the two. So what we're going to do is get Rob to tuck his elbows in there, come out a little bit, and we're just looking to check active range of movement of external rotation. So we're just going to get him to turn his arms outwards for me there. Good, and then come back in. So if he's got full movement, as he has there, then we can consider that this definitely isn't going to be a frozen shoulder, contracted shoulder. Okay. If he didn't have full movement, so he was restricted into that external rotation, then he could possibly have a frozen shoulder there. To clear that, what we need to then do is test the passive range of movement. Okay, so we want to ensure that the arm's fully supported. Now this is important, okay, because we don't want any restriction from the patient guarding because they're in a lot of pain. And then just rotate that joint out yourself. Okay, and if they have got the full passive range of movement, again, we can consider that this is not a frozen shoulder, it's not a contracted shoulder. If they did get stuck there, okay, they had a restricted range of movement, you couldn't take it any further, and you were happy that they weren't guarding because of pain, they got a kind of true stiff end feel, then a frozen shoulder is certainly a possibility. Okay, so what we need from there then is a referral for an x-ray to clear any chronic dislocation, anything sort of sinister, any sinister pathology there, or any osteoarthritis that could be causing the symptoms as well. Okay, and once you've sent them for an x-ray, you can refer through physiotherapy or get the patients to self-refer themselves. So that's frozen shoulder. Moving on from that, if the movement is there and they've got full passive range of movement and or full active range of movement, we can consider this maybe a subacromial pain or a sort of rotator cuff dysfunction. The way we can test this is we're going to use the same movement, but we're going to resist against it. All we're going to do is apply a little bit of pressure on the outside. Okay, and what we're looking for is pain and or weakness. Okay, so if it's painful or weak, then we can consider that is a subacromial pathology. What we need to do there is ensure that the patient is adequately medicated, that they avoid any aggravating movements or activities, and again refer them on to physiotherapy, get them to self-refer to physiotherapy as soon as possible. If that doesn't bring on any symptoms, we can move on to sort of the third area of what could be a shoulder pathology, and that would be an instability at the shoulder. So again, using the same movement, what we're going to do is get Rob to take his arm out into abduction and external rotation. Now what we're looking for here is any apprehension, any pain or clicking, popping sensations, which might indicate that there's an instability at the shoulder. If it's an unstable shoulder, they're really not going to like going out into that position. They're not going to want to. Contrary to sort of beliefs in the past, these patients don't need to be referred straight onto the orthopaedic team. We can manage them here at physiotherapy, and often conservative treatment is considered sort of the best option first. So get them referred to physiotherapy, and we can start them on their rehab program. So just to summarise, if they've got restricted active range of movement and passive range of movement, it could be a frozen shoulder, X-ray and refer to physiotherapy. If they've got their full movement, either actively and or passively, but they're pain and weak on resisted movement, it's likely a subacromial rotator cuff pathology. Or if they really don't like going out into abduction and external rotation, then potentially an instability. Manage their pain levels with medication as you see fit. Advise against sort of the aggravating activities, and get them to self-refer to physiotherapy.